But I will turn off the recording. If I don't, somebody remind me after the presentation so that the Q&A and discussion is not recorded. The recordings for the sessions will be posted to the Safety Net website. And as soon as they're up there, then I will provide you with a link to the recording for the first and the other sessions. And that's partly so that we all have a resource that we can go back to as we move forward and into the future. But also there's a couple of people, for example, who couldn't join today. And part of the understanding is that they will review those recordings so that we're all sort of on the same trajectory as we move forward. So, I mean, essentially, this event is being sponsored by Policy and Practice and Return to Work. That's University of Ottawa, SSHRC and Canadian Institute for Health Research funded partnership grant that was initially headed up by Catherine Lapel, who's the Canada Research Chair in Health and Safety Law at the University of Ottawa. Unfortunately, she passed away about a year ago. And Stephanie Premji at McMaster, one of our speakers today, and Alan McKechnie have taken over. Alan will be speaking in the next session, running that larger grant. And it's also co-sponsored by the Safety Net Center for Health and Safety Research, which most of you may be familiar with. It's based at Memorial University, and Kim Cullen, who's one of our speakers today, is a co-director of that center. So the larger project of Policy and Practice and Return to Work is somewhat more narrowly focused than we will be in this particular dialogue. It's focusing on return to work for particular groups where there's some significant challenges, and we will be hearing about some of those groups, such as immigrant workers. Stephanie will speak to them. We're looking at mobile workers. Chris McLeod is working with us on some of that work. And some other groups, mainly precariously employed. But for us, we're looking more broadly at the issue of return to work. And so there'll be two sessions. This is the first one, where we'll be presenting on some of the research that's been happening over the last few years on return to work in Canada. And then in the third session, Anya Keefe, who's with us and will be helping me sort of co-moderate this session, will be presenting. She's doing an environmental scan of return to work policy and practice in different Canadian provinces. And Anya, you can put your hand up, Anya, if you want. We'll be presenting our draft scan, so comparing those other provinces and some other jurisdictions to the Newfoundland and Labrador policy and practice on return to work. And so that will be discussion of that draft document will be the focus of the third session. And then the fourth session, there'll be a synthesis of what we've learned, and are there any recommendations for future research and action for Newfoundland and Labrador. So that's the structure of the dialogue. And I'm not going to say a lot about return to work. There are more experts, people who are on this call who are much more expert than I am on this subject, who will, I think, introduce the concept. Just a couple of other housekeeping items. So we're going to be polling you electronically as we go forward. Bojan First, who you can see up there, he's with the Harris Center, and he's going to be running the poll for us. And so over the course of the session, he will launch questions. I can't see them, so he'll tell you what the questions are. And we'll just ask you to respond to those questions if you wish. The responses are anonymous, and we'll get sort of immediate feedback in terms of what people have responded to those questions, and that helps us. We have a large group, so it's difficult. And we also have a number of presentations and comments and reflections today. So it's difficult for us to get into any sort of detailed Q&A and discussion in this first session, but the polling will at least give you an opportunity to provide some input and thought. as we go forward. So the structure then is we'll open with a panel. Our first speaker is Stephanie Premji, who I've already mentioned is the new co-lead of policy and practice in return to work. And she'll be introduced the larger project and talk about the research that she's done on immigrant workers and return to work. Our second speaker is Kim Cullen, who I've also already mentioned, who is the co-director of the Safety Net Center for Health and Safety Research, and she's been doing quite a lot of research now for quite a long time on return to work, including systematic reviews and other types of research when she was at the Institute for Work and Health, and is now doing research on return to work here in Newfoundland and Labrador. Then it'll be Chris McLeod, who's at the University of British Columbia, and again has an extensive background in the field, as does his center that he runs at the University of British Columbia on return to work. And then we have two speakers who kindly agreed to, they both have great depth of experience around return to work and workers' compensation and other issues in Canada. So we have Alec Farquhar, who was formerly with the Office of the Worker Advisor in Ontario. And we have John Beckett, who is with the Maritime Employers Council, and is a former chair of the board of workers of WorkSafe BC. And they are going to both reflect on what other presenters have said and provide us with some insights from their significant depth of expertise in this field. And then once we're through that process, then we can move to questions and answers. So what we'd like to do is for the Q&A, what we'll do is we'll ask you to post your questions in the chat. Anya Keefe will be monitoring the chat and will pose the questions for us once we get through the presentations. But we'll move through the presentations first and then move to the question and answer. So please use the chat. Feel free to use the chat. If you've got resources or ideas or thoughts you want to post in the chat, please go ahead and do that. I love the way people have made chat their own over the course of COVID. It's been really interesting to watch. So I think that's all I have to say. Anya, have I missed anything? Nope, I think we're good. So again, looking forward to this event, and thank you very, very much, all of you, for joining with us today. So Stephanie, I think you're up.
Okay, thank you, Barb.
Oh, no, sorry, I forgot. First question. Boy,
we have some warm-up questions. So you should be able to see a poll on your screen. I leave it up for a minute. And do you see the poll on your screen? Yeah. Good. Answers coming in fast. Okay, a couple more seconds. So your last chance.
I don't know about others. I can't enter text. Is anybody else having trouble?
Oh.
It's the same. I can't select an option for some reason.
Oh, I'm sorry about that. All right, let's
I think
close.
it's a speakers. I don't think can input into the
Speakers cannot answer the speakers cannot answer the poll. Sorry about that. Okay, let's end this one. And I'll share the results with everybody. So we have some of the time, as you would expect in most cases. And for the three things, we have doctors, lack of functional ability assessment, poor communication between all three parties. We have worker cooperation, lack of medical information. We have non-cooperation with injured employees, as well as accessibility to healthcare in a timely manner. I'm not going to go through all of them because there's a lot of answers, but we will share them at the end of the event with everybody. Okay.
Thanks a lot, Boyan. Okay, Stephanie, do you want to pull up your presentation?
Okay, let me just go ahead and do that. Okay. Well, does everybody see? Okay, perfect. So thank you so much, Barb, for the introduction. So as Barb mentioned, the work that's presented is part of a large research project that brings together researchers and partners from across the country to study how return to work policies and practices are implemented in various work contexts through various case studies. So the projects look at experiences of recent immigrant workers, workers with mental health conditions, and workers engaged in employment-related geographical mobility, including international migrant workers. And the goal is to tie the experiences of workers to the policies and practices of the various systems and actors that are involved in workers' compensation and return to work. The larger context of the project is one in which the management of work injuries and illnesses by workers' compensation systems is increasingly focused on maximizing economic gain and minimizing economic loss, with at times devastating consequences for workers. The context is also one in which workers are increasingly falling through the cracks as policies and practices are ill adapted to workers' reality, including growing forms of work such as precarious work. As Barb mentioned, the project was the initiative of the late Catherine Lepel, who sadly passed away last year. Our team was unanimous in wanting to complete the work that was started, and our objective is to develop recommendations for policy and workplace practices that promote sustainable return to work for all workers. So one of the projects that is part of this partnership is one that I conducted. It's a community-based project that I conducted in partnership with the South Asian Women's Rights Organization in Toronto. It's a small community-based organization that works with primarily Bangladeshi women. And in the community, there are very high rates of precarious employment, in particular employment through temporary agencies. So we documented, perhaps unsurprisingly, that few work injuries and illnesses are reported to workers' compensation, which, as we're going to see, impacts return to work in various ways. So today I want to give a brief overview of our findings and also briefly talk about what happens when immigrant workers do engage with workers' compensation and return to work. And I'll do that by focusing on the issue of language barriers, which is an issue that I investigated in 2 previous studies. So first, I want to talk about our study among the Toronto Bangladeshi community. As I mentioned, there is widespread precarious employment and also widespread health problems due to work. And we don't have data specifically on the Bangladeshi community, but there's lots of evidence that racialized immigrant workers experience disproportionate rates of injuries and illnesses compared to other workers. So the question that we asked was, what happens when you get hurt or sick at work when your work is not stable or secure? I don't want to go into the methods too much, but just to briefly explain what we did, we worked with peer researchers who are Bangladeshi women with direct experience of precarious employment, whom we trained as researchers. They conducted interviews between August 2020, August 2021, and interviews were conducted with 45 workers and 11 key informants. Most of the workers that we spoke to were women, had children, they were married. The majority had been in Canada for 10 years or less. What's interesting is that almost all had a post-secondary education, but they worked in low prestige, largely shift-based jobs in factories, in retail and restaurants, childcare, and security. So to answer our question of what happens after a work injury or illness, well, typically workers did not report their injury or illness or delayed reporting because of various factors. And actually, usually workers waited until their injury or illness was quite severe until they reported to their employer or filed a claim with workers' compensation. And their response was shaped by a number of different elements. The first one is lack of information. So workers sometimes lacked information, weren't sure if their illness was work-related, didn't know about workers' compensation. Sometimes they thought the injury or illness was their fault, or that it wasn't serious enough to report. Also, often they didn't know who to report to, and this is especially significant in a context of multiple employers, where sometimes workers had multiple consecutive or concurrent employers and had a difficult time really identifying the incident employer. Another factor that shaped workers' responses was claim suppression by employers. And we found that claim suppression was extremely common and experienced at various stages of the claim. So not just to discourage workers from filing a claim, but also pressuring workers to drop their claim or to return to work as quickly as possible. And one strategy that employers used was to promise accommodations that then would not materialize. There were also issues with doctors who didn't want to engage with workers' compensation because they found it too burdensome to do that. So as a result, we heard that doctors sometimes didn't mention work or didn't mention workers' compensation, even when they suspected that the injury or illness was work-related. Another factor was the workers' compensation system itself, which is very complex, adversarial. One issue that really discouraged workers from reporting was the income replacement rate in Ontario of 85%, which was very difficult for low-income workers, especially considering the high cost of living. And as in addition to that, another factor is the overall precarious work context. So workers not wanting to jeopardize their current employment, also their future employment. So as a result of all of these factors, most workers continued to work until they couldn't, until it became so severe that they had to stop working. And I want to just read you this one quote from a worker just to highlight the issue of claim suppression. Anyway, I thought I would get some support from my workplace. I thought they would give me benefit for the days I was unable to work, but they were continuously pressuring me to return to work the next day. I mean, my manager called me the next day. I became afraid and thought that if I don't go the next day, they might fire me. I needed that job. So the impacts were many. And delayed or non-reporting was hugely consequential because it impacted the long-term health and well-being of workers. It impacted their access to workers' compensation because claims were rejected. And it also impacted their ability to recover and rejoin the workforce. Often problems became really aggravated, and workers had no formal access to return to work supports and services. So when they did return to work, usually they would do so on their own and they would essentially find a new job. So because very few workers in our study had actually engaged with workers' compensation, we didn't have a lot of information about their experiences with return to work services. But in the past few years, we conducted 2 studies in Ontario and in Quebec that also looked at immigrant workers, specifically the issue of language barriers in return to work. And I briefly want to outline a few points from those studies. So what we found is that, first of all, we found that there were significant gaps in language accommodations. This was particularly the case in Quebec, where workers were responsible and are responsible for finding and paying for interpreters, so that many workers actually navigated the process without being able to fully understand what was happening. And these gaps in language accommodations had all sorts of impacts. So it resulted in delays, in misunderstandings, in claim complexities. And this sometimes postponed and sometimes prevented diagnosis, treatment, rehabilitation, recovery, and return to work. For example, workers reported not fully understanding decisions, even when interpreters were present, and therefore not following their return to work plan. So there were significant gaps in language accommodations, but there were also problematic return to work policies and practices that really shaped workers' experiences. And I just want to briefly list a few. There were limited options for return to work in the pre-injury jobs because modified or accommodated work usually involved manual labor or official language skills. And also return to work was very difficult and pretty much impossible in the context of temporary employment agencies. Accommodations were also often unsuitable, which in many cases exacerbated the injury or caused re-injury. Workers also had to deal with a toxic work environment, a difficult relationship with employers who sometimes tried to push them out to quit. There are also the issue of inadequate assessments, because what we found is that the assessments, whether for skills or language, didn't properly capture workers' skills and abilities. We also found issues with training. Low-income workers in both provinces, in Ontario and Quebec, were unlikely to be offered training because it was deemed unnecessary to restore the pre-injury wages. And in cases where skills or language training was offered, key informants reported that it was typically for a short period of time, and that the training lacked in quality. And I just saw the message that I have 1 minute to go, so I'm going to wrap up quickly here. And one important point is that workers were excluded from decisions because of language barriers, but more generally, because of the lack of opportunity to contribute to the decision-making process. And I just want to just read this quickly. This is a quote from a legal representative. And she says, like, customer service representative for one of my clients, and he's not even capable of writing one sentence in French. So there is a problem. or a worker to whom they wanted to give, I think, another customer service job, but she struggles to express herself verbally in French, and then another. But for that, we had been able to invalidate the suitable job at the tribunal for this reason particularly. So this gives an example of how the determination of suitable job is inadequate in context of language barriers. So in conclusion, I just want to say that we have our results from our study with the Bangladeshi community in a draft report that I'm happy to share. If it's not online anywhere, but I'm happy to share that by email. We also produced a guide, which is online, which is a guide to identifying and addressing challenges related to language barriers in return to work. So I have the link here, and I'm happy to send that to Barb as well to send out for those who might be interested. Thank you very much.
Thanks very much, Stephanie. So I think two big take homes from Stephanie's presentation. One is that and when thinking about return to work, we can't only look at the statistics from workers' compensation, because not everybody actually files a compensation claim, and there are particular groups that are more or less likely to do that. The second thing is just a reminder that, and we're going to pick this up in the next polling question, and that the composition of the labor force in Newfoundland and Labrador is changing, and we have thousands of international students who are at the university who are now eligible to work, a full week if they want to. They're in the labor force. In addition, we have Ukrainians and we have growing numbers of immigrant workers here. So, Boyan, do you want to post the next question?
Sure. So your next question is everything that Barb just said, and then how do you think the changing labor force is likely to affect the overall outcomes of return to work in the province? Here is your poll, and I'll give you a minute. Okay, a few more seconds to get those answers in. And done. Here are the results that you should be able to see now. So obviously nobody thinks this is not going to have an impact, but it varies between some impact to possibly significantly negative. Okay.
Okay, our next speaker is Kim Cullen. Kim, do you want to pull up your presentation?
Sure. Okay, you should see that now. So my presentation is focusing on taking a step back and thinking about what do we know. As Barb mentioned, it's been a long 20+ year career for me in doing research and return to work. And I wanted to give you a sense of some of those highlights from that work. I thought briefly before I touch on that, I might speak a little bit about Safety Net for those on the call who haven't heard of Safety Net or are wondering about what we do. We're a research center, Eastern Canada's only community university center focused on OHS research. And we have a three-pronged mandate. So one is to conduct high quality multidisciplinary research. And that's a number of our scientists here at Memorial are connected to researchers across Canada doing that work. We are also in the business of trying to help facilitate this knowledge that is happening in research, and also from our community partners, putting those people in touch with each other and allowing that conversation to unfold. And then the third thing we're in the business of doing is trying to build OHS capacity within the province. So we have trainees working with us on our research activities. And we also have a fairly new Master's in Occupational Health and Safety that you can take here at Memorial that we administer as well. So turning back my attention to what works and return to work, I'm going to speak a little bit about what the research evidence tells us are the most effective things we can do. And then I'm going to poke some holes in that over the next set of slides. So from a series of systematic reviews that I've been involved with since the early 2000s, looking at more than at this point 70 original studies, our research question has always focused on what can workplaces and system partners do? So when I say system partners, I mean compensation authorities, or also safety sector councils who might be producing programs to be directed at a group of workers. What can these parties do to help workers with both musculoskeletal and mental health conditions in their return to work after a period of work absence? And when we have been focusing on return to work, we're talking about how do we reduce the length of time people are away from work and the costs that are associated with those times away, but also how do we improve that work functioning as people return? How do we improve the ability of folks to do work when they're on their transition back? So the Coles Notes version of this series, how do you take 20 years of work and put it into one slide? We have been able to identify that there tends to be three types, so three buckets of intervention approaches that are successful in helping workers in the return to work process. One would be on health-focused interventions, things like providing access to the care, the health care that people need. That could look like physical therapy, it could be medical treatments, it could be other forms of treatments like psychological therapy as needed. A second element of important intervention approaches is to actually help people navigate the system. So we call this service coordination. This involves communication among parties. And I say on this slide, early and compassionate communication. It involves planning and coordination and helping workers who, for the most part, may be experiencing their very first time navigating the system, understanding what they need to do. And then the third group of intervention approaches that are helpful would be things you probably already are thinking about: work modification. So changes of duties, changes in hours, making accommodations and adjustments to workstations or equipment that workers are engaged with. But the really important thing is that these approaches don't work so well in isolation. They work best when you pull as needed from each of these three areas. And so I like to say that you want to take an individualized approach. Something that will be helpful for one worker may not be necessary in another case. And so it's important to be thinking about how can we customize the experience for an individual using a broad brush across these strategies. So that sounds simple, but in truth, it turns out that it can be really complex. And we've just heard from Stephanie a number of some of the challenges that you might face. So I want to actually walk through, for each of those three categories, some of the challenges our research has shown to create barriers or problems. So barriers to access. If healthcare services is an important element of providing care to people as they need it to help them in their transition back to work, having access to those services can be a critical element. Here in this province, we know that there is a shortage of primary care physicians. I've been here myself for 4 years, and I've only just managed in the last 6 months to get on a collaborative care team for access to healthcare services. So if I was in the middle of trying to deal with a return to work injury, access to care could be quite a problem. In addition, we see quite long durations of wait times for access to specialist appointments or other care providers, particularly so when we're talking about mental health. And then when we're thinking about mental health, there are alternative services So if you're waiting to get in to see a psychologist or a therapist, you might have access to an employee assistance program through your workplace, but we know that those have limits themselves, that there may be a tiny amount of treatments available before that service would run out. Other barriers to access could include being related to geography. So for our rural or remote workers, those create difficulty for them. And then we have workers who our mobile workforce in particular, who may be working in remote settings or offshore, that may not actually be able to access that care. So it's one thing to say, well, we'll give you flexible hours so you can go and get your treatment in between or during your workday. But for some workers, that's physically impossible. Another challenge thinking about the health-focused elements is the systems are designed so that healthcare practitioners are part of play a gatekeeping role in return to work. They have forms they need to fill out. They assist in determining the guidelines for work accommodation or modifications that may be necessary. And there are challenges here as well. Most primary care practitioners are not trained on understanding occupational injuries or to think about hazards and demands of work. And then even if we can find engaged and accessible, informed healthcare practitioners, sometimes their scheduling doesn't work well with the scheduling needs of a return to work process. There are other inequalities. And so one study that I was involved in looked at whether workers were experiencing inequalities in return to work by sex and gender. And in this case, we were able to show that men tend to receive more specific diagnoses. Women, because of the nature of the work, often have non-specific symptoms and their diagnoses are challenging, which creates treatment plan issues. You can imagine finding an excellent treatment plan for a specific injury, but for non-specific ones, that can be more challenging. And so that also limits their access to guidance on gradual return to work when if they're in work that is deemed sort of light or sedentary levels, it's often assumed that no accommodations may be required. And so gradual return to work programs are less frequently used with workers that are women. And we can see failures as a result of inability to see their symptoms resolve in result from those experiences. Service coordination challenges. We often focus attention on the worker and we neglect the idea that the psychosocial working environment may not always be positive. We sort of get into this thinking that the relationship between the workers and the psychosocial and interpersonal relationships will be good in these workplace settings. And when all goes well, that's really important. But primarily we see that that isn't true for a large number of workers. And so in those cases, it makes things more challenging. We just heard some of the examples of how we might have issues and barriers for precarious workers. We see signs of claim suppression, there's fear of reprisal, and they often have an inability to access return to work, gradual return to work programming. The ability to get connected back to their workplace may not be there. In construction, for example, if the job is finished, there may not be a job to go back to. And then there's coordination across multiple systems. I've spoken about this a little bit. We have issues in accessing healthcare. There may be multiple compensation authorities involved or other third-party insurers, particularly so for mobile workers who may be injured in one jurisdiction but living in another. We've got to deal with our workplace as a system. And there may be cost shifting that's going on. So as we get to the end of one program and there's tightening time limits to get someone through a program, they might be shifted to a new program, and that can actually create and introduce some delays for workers in their return to work experiences. The last one I wanted to focus on was challenges in work modifications. Of course, work modifications are not always easy to implement. We're getting older. We're always getting older all the time, and older workers face greater challenges in return to work. They have increased healthcare needs and they take longer to recover. So this can create some delays. It may be harder for small workplaces to make these accommodations happen. And then there are industries with particularly heavy physical demands that are not well suited to trying to do changes to the demands themselves. Sometimes early return to work can actually pose risks to self or for coworkers, particularly so in safety sensitive contexts. I'm learning a lot more about the offshore work environment since I've moved here, and there are times when it moves from doing work as typical to trying to address inclement weather, and you move from work as usual to survival, and workers that may have restrictions in their demands may pose challenges for themselves and coworkers around being able to do what's needed for survival. And then we have other industries where the burden on coworkers increases as we introduce lower demands for certain workers. It might be picked up by others. We see that quite readily in the healthcare sector. And then in certain cases, particularly so with offshore work, there may be other systems. So there may be other regulations that say there needs to be certificates, such as a fit for work certificate, that workers can't go back to work until they're deemed fit for service. And that might influence our ability to actually get people in through an early system and doing modified duties. So there we are, what works in return to work. A multidisciplinary approach is a very important piece of the puzzle here. We really want to tailor return to work to the individual, but the devil really is in the details. And so together we need to do this project. We need to think about return to work using this team approach. Together, everyone achieves more. Researchers are studying the effects of policies and programs on individual workers and across jurisdictions. Workplace parties are solving problems every day, and we need to tap into one another to really get at the issues and understand the problems. Thank you.
Thanks so much, Kim. Sorry to make you compress 20 years of work into 10 minutes. The good news for the participants is Kim was with us. She's a member of the organizing committee for the larger dialogue and will be with us right all the way through. And of course, she's at SafetyNet if you need to get in touch with her. So, Brian, I think we have another question.
We do. We have one question for you. The question is, in my experience, return to work is more likely to be sustainable when? And then pick your favorite answer. Again, I'll give you a minute. Okay, a few more seconds. And done. As we heard in the presentation, there is no silver bullet. It all has to work together. Alrighty, thank you.
Okay, Chris McLeod. There you are, Chris. You want to put your presentation up?
You bet. Just let me get going here. Cast. I will just put it up. All right, everyone can see that all right?
Yeah.
Great. So great to be here. I'll note that while I am from British Columbia, I am sitting in SafetyNet offices in St. John's giving this presentation because I've was here to present at the Construction Safety Conference yesterday. And I'm on my way to the airport, and I'm getting texts from Air Canada progressively saying that my flight is delayed. So we'll see whether I get out of St. John's tonight or not. I'm really happy to present our findings on a program of research that in some sense is very complementary to what Kim just shared. And in this case, on the West Coast, we've been focusing on looking at successful ways of improving return to work with largely using workers' compensation and linked data from WorkSafe BC. In today's presentation, I really want to highlight some research that a postdoctoral fellow of mine and I collaborated on a few years ago, Dr. Esther Moss, who's now an assistant professor in Newfoundland, and looking at how we can understand the effectiveness of gradual return to work in the context of a Canadian workers' compensation system. So I just want to spend 30 seconds on who we are in terms of the Partnership for Work Health and Safety. We are a research unit at the University of British Columbia, where our key partner is WorkSafe BC, where we've been studying policy relevant issues around occupational health and safety and return to work for over 20 years, primarily focusing on using linked administrative data. The focus of my presentation is gradual return to work. I think it comes on very nicely or follows very nicely from Kim's presentation, where she summarized 70 studies looking at various aspects of return to work. This is a set of studies that focus on a specific aspect of how we can improve return to work. And you can see the definition of gradual return to work on your screen in front of you. And we're really talking about a broad range of activities and tasks, similar to what Kim defined in the previous presentation. So what I'm going to cover today is based on two papers. First of all, the first paper focuses on just who is offered return to work within the context of the British Columbia workers' compensation system with workers with a musculoskeletal injury. And then the second one actually turns to that effectiveness question. So does return to work as an intervention or as a strategy actually improve either the time to return to sustainable return to work or the likelihood of sustainable return to work? So in this context, and this is a little bit different than Kim's presentation, where we're summarizing findings from 70 different studies, we're really exploiting and using the power of linked administrative data within the context of a workers' compensation system and a healthcare system in British Columbia. And we're able to link our workers' compensation data to a wide variety of linked administrative data, including demographics, hospitalization, pharmanet, physician visits, and the like. And this allows us a very powerful tool in terms of understanding the effect of compensation policies and specific activities at the population level. And so the two studies that I'm exemplifying today or drawing on today use various forms of this linked administrative data. So the first one looks at the determinants of return to work. It was published a few years ago in JOEM. You can see the citation there, and also happy to provide the paper to you if you are interested. And so in this case, we're really looking at who is offered return to work writ broadly. We've also done some subsequent research on this, looking at issues related to immigration status, but I'm not summarizing that research here today. So drawing on almost 140 or 150,000 accepted workers' compensation claims, representing 32,000 employers over a 6-year period from 2010 to 2015. And so we're just looking at who is and who isn't. So here you have a nice picture showing the number of injured workers with a work-related musculoskeletal disorder in British Columbia. Got the total number of claims, so that's somewhere around 25,000 claims each year. And you can see the proportion or the number of claims overall with and without gradual return to work. So at the beginning of that time period, few claims, or the majority of claims, somewhere in the neighborhood of 7,000 or 8,000 had gradual return to work, and 15,000 did not. And over that period of time, we essentially saw a gradual increase in the offer of gradual return to work, so that it increased to approximately equal proportions. So about half of injured workers were receiving graduated return to work at the end of this time period, and half not. But we can see that there are really big differences by industrial sector. So this now is just moving from the count to the percentage or proportion over this period of time. Now there's an upward trend across all sectors, but you can certainly see that sectors like retail, wholesale trade, and manufacturing start high and move higher, such that at the end of the time period, retail and wholesale trade, it's almost 60% of injured workers receive an offer of graduated return to work in that sector. In contrast, when we look at construction and primary resources, very much consistent with what Kim said overall, the proportion was low to begin with. While there was an increase, it still was a minority of workers at the end of that time, around somewhere in the neighborhood of 40 or less for construction, primary resources, and also, I believe, transportation and warehousing. Other differences, again, no surprises here, that there's a really large effect and pattern by firm size. So looking at very large employers down to small employers with less than 20 FTEs. The increase, though, is relatively constant, but that sequencing in terms of smaller employers offering graduate return to work much less often than very large employers remains the case over the study time period. Certainly, lots more findings in that study, and given the time constraints, I would invite you to look at the study itself, because we did find significant individual variability. So in this case, more gradual return to work for workers with fractures, middle-aged workers, higher wage workers, and a little bit of a different finding in terms of what Kim mentioned. We did find in British Columbia, women were more likely to have received an offer of graduated return to work compared to men, and that was after controlling for industry or occupational characteristics. Certainly more gradual return to work with larger firms versus smaller firms, and we see this sort of secular increase in gradual return to work over time that we would expect to see if we had continued the study for later years, although I think the increase would begin to taper off. So that just gives you a high level picture of who and some of the characteristics of those individuals that receive gradual return to work. But ultimately, we're really interested in how well does gradual return to work as a strategy to improve time or increase the likelihood of sustainable return to work. And that's what the second paper focuses on. This is more recent, just published last year in Occupational Environmental Medicine. Turns out this is a really hard question to answer, because gradual return to work is both an intervention, but also a form of return to work. So how do you develop and design a study that studies something that is very much like your outcome in terms of thinking about how it can influence the outcome? So Dr. Maas, Esther, and I spent a lot of time working on this from a research and methods perspective. And we think we've more or less cracked the nut, although I think there's more research to be done in terms of unpacking or disentangling gradually return to work, which is a form of return to work, with as a distinct influence on sustainable or ongoing return to work. So I'm going to try to walk you through that over the next 5 or 6 minutes. So again, a large sample, I'm not going to go into this. Musculoskeletal claims. In this case, the key thing here is we have essentially a control sample and an exposed sample. So very carefully, or as detailed as we can with this linked administrative data, matching individuals with graduated return to work and no graduated return to work. So they're as similar as possible in all other contexts, except for the offer of graduate return to work in the context of the data that we have. Using a variety of methods, approaches. In this case, I'm just going to show you some descriptive results, so I'm not going to go into the analytic approaches. I'll refer you to the paper where we outline that in great detail, but move to the results. So this is a simple graph. What it shows is the effect of graduate return to work on sustainable return to work, where on the y-axis you have the proportion of workers who return to work in the sample after by month, and then you have those that did not receive graduate return to work and those that did not. Now, what's interesting here, when you kind of conceptualize graduate return to work as distinct from return to work, what you see is you actually see a little bit of a delay to return to work. And that makes sense because people are back at work, but they're not fully back at work. But what we do see here is once we get out to about 7 or 8 months after injury, is that there's a greater proportion of those workers who ultimately return to work. So it has an effect, a durable effect on sustainable return to work overall. And when we run that out quite far, so 2 years of follow-up, we can see that that's a durable finding. Now there is a ceiling effect of around 80% of individuals going back on sustainable return to work, but you can see that ultimate intervention effect that really emerges around 9 or 10 months and then plateaus around 15 and 16 months, the difference between the two lines there. Now, there are differences. So we actually see a different pattern with women compared to men. So women, there's a greater durable effect on sustainable return to work. So the dotted line ultimately is higher, whereas with men, we don't see that. We do see this differences when we think about gender and industry. Again, these are just examples. You can look at the paper if you want to know more. Again, the effect shows up more amongst women in given sectors compared to men in other sectors. Interestingly, the effect is very pronounced by injury type. So when we look at torso strains and rheumatism, we see this effect is greater. So a little bit of that bringing people back to work early, so they don't necessarily go back to sustainable return to work earlier, but when they do return to work, a greater proportion of them returns to work. And that's much more amplified amongst torso sprains and rheumatism, but we don't see that pattern with lower fractures. So essentially, when we look at fractures, what we're seeing is graduate return to work essentially returns individuals to work faster, but they're on graduate return to work during that period of time, but there's no difference in the sustainability, the overall sustainability of return to work. Now, when we change the definition, so this is sort of taking graduate return to work and saying, okay, it's actually return to work. So we're going to group graduate return to work with sustainable return to work. And here what we see is there's less of that effect in the 1 to 4 months. Certainly people are, the two lines look very similar to one another, but then what we see is we see a much greater divergence. So what that tells us is that graduated return to work can be an ongoing or durable strategy for some workers who may continue to have ongoing impairments. Just in terms of my key findings and wrapping up, graduated return to work is not effective for everyone and in every circumstance. Looks like it's effective for longer claims with longer duration, especially for those that may need accommodation after 12 months, representing moderate to severe injuries. And I would also say that this study, I think, shows the power of using workers' compensation data in a linked administrative data context, because we wouldn't be able to look at this type of work from a systems or population level unless we weren't able to do that. So I know that's an awful lot of information in a short period of time. I do want to acknowledge the research team, particularly Dr. Moss, of which this research represented her postdoctoral research, but also the data stewards, and just note that these are our opinions and don't necessarily reflect the opinions and conclusions of the funders or the data stewards. And I will close now, and thank you very much for your attention.
Thanks very much, Chris, and it's great to have you in Newfoundland, even if only briefly. I hope your journey home is on time and safe. So I think we have another question, Boyan. Is that
Yes,
correct?
we do.
Yeah.
And this one is another short answer question. So 200 characters or less. In your experience, what types of injuries tend to result in the implementation of gradual return to work options? So I'm going to give you maybe 2 minutes. About 20 seconds left.
Chris, I think you're unmuted.
Oh, sorry.
I feel like I'm on Jeopardy.
Alrighty, let's close this one. And I will share results again. It will not show you all of it. So what we have here is physical rather than mental illness or injury. Otherwise, I'm uncertain. Back injuries, broken bones, lower back injury, strains, sprains, lower back injuries, physical injuries, larger employers for a diversity of job types. And that's not all. Again, we'll share all of it in the after the session.
Okay, thanks very much. Okay, so now we have our two discussants. We're going to go first to Alec. Alec, you have a presentation, is that correct? If you do, can you put it up? And again, Alec is going to speak from his extensive experiences when he was in the Office of the Worker Advisor in Ontario and many other jobs.
So this is real time. So I'm going to save this. I've been trying my best to harvest sort of the gems from these great presentations. So just give me a sec. And I just saved it. Now I'll share screen and hopefully you will see it. Doesn't seem to let me share screen. Is that? Let's see if it'll do it this way. There we go. And okay. So are you seeing my slides?
Yes, we are.
Okay, great. All right, I'll put up full slideshow. There we go. So thanks so much for having me. This is a really fantastic sort of process and setting for dialogue. And that's what I'm really committed to contributing to. So I do have a worker hat on, but hopefully you'll be seeing me taking it off to some extent in the conversation. And I'm deeply committed to collaboration by the workplace parties around RTW, and I'll be commenting a little bit from that experience. I've been part of some really big, successful collaborations from which much can be learned. So first of all, just as a sort of a starting point, I'm going to put up my own ideas and also harvest from others. So it'll sort of, you have to take a little bit of care because I've done it so quickly to figure out what's me and what I'm quoting. I hope I'm making it clear when there's a source from one of the three presenters and when it's me. So I'll start with me. Return to work must be integrated with primary and secondary prevention, not in a specialized silo on its own. To me, the most successful workplaces do that. Where it's a specialized area for HR, doesn't work out too well. I'm really committed to seeing the prevention collaborations that might happen, contributing to a culture more supportive of disability disclosure and accommodation. I've seen that happen, especially where the employer and labor or the workers in general collaborate on deep issues, such as prevention of violence from clients, patients, or customers. When you're all committed to protecting each other, it can make a huge difference. We had some really important contributions from the Cullen presentation on workplace parties, not just being alone in this, but of course the vital role of healthcare providers and other supportive services. And employers can be helpful in supporting workers who face the kind of barriers to access to services that were in that presentation. And also, I was really interested in the idea of better coordination of supportive services. So many RTW cases fail just from that lack of the right information from, for example, a doctor at the right time. I want to speak to the case for change really briefly. Some of this is me. Some of this I pulled from the Premji presentation. To me, the case for change has to be meaningful in the workplace. It should include the full range of financial and human impacts. WCB claim data will often not capture the full picture. I took that from Premji, and sometimes it's from claim suppression. Sometimes it's just because things aren't captured, especially at the early stages. I'm a real proponent of using survey data and other qualitative data as well as the sort of dollars and cents. Employee surveys, for example, one I was part of inside the Ontario Public Service, can have a very powerful impact when workers report that, only 20% of them trust that their senior management cares to accommodate their disabilities. When you get findings like that, you sort of have to wake up and do something about it. The McLeod presentation showed us how much can be learned from big data studies that could be then applied to workplace settings. It's, of course, often really hard to translate learnings into specific settings. You've got to be careful and analytical. So I'll put my worker hat on here, I guess. I believe that return to work structures can't just be run by the employer. They have to include the union where there is one. And I've been part of some marvelous collaborations along these lines. And there's often an elephant in the room. If what's really happening is a technical approach by the employer, such as hard-edged attendance management programs, that'll undermine just about everything. Because if you're the union, you're going to be litigating that. You're going to be challenging that. You're going to be there with the worker when they meet the manager and all the rest of it that comes with it. So I really believe employers and unions ideally will choose a collaborative approach rather than a technical approach. If you're going to collaborate, you have to invest in it. You'll get a good return on investment if you put the resources in at the beginning. A lot of that can go to education and awareness raising. And so many workplaces now take the shortcut of short internet-based sessions where people are doing their emails while they're on the session. And it's so easy to pass the test the thing is out of your mind practically as soon as it goes in. Not good. I really want to see in collaborative efforts, workers and employers, managers actually putting themselves in the shoes of persons with disabilities and realizing tomorrow it could be you or me, but today it happens to be the injured worker. Individual cases should be addressed in a broader context, ideally with the learnings from one case, for example, prevention and return to work, being harvested to support better outcomes. But the Cullen presentation is showing us that what helps one worker might not help another. It can't be a cookie cutter. Premji and Cullen spoke, especially Premji, to intersectional barriers such as language, gender. Workers who face such barriers must feel safe and supported in raising concerns and asserting their needs and rights. And I found that often return to work can be positioned within broader initiatives. And I think there's real territory here, right across Canada, to include return to work and disability issues in broader diversity and inclusion initiatives. Cullen noted the impact that can happen when an injured worker is accommodated in a way that places additional burdens on co-workers. That's one reason I really like a deeper analysis linked with primary prevention. I'll just give you one example. A very large healthcare employer that I work with a lot, where there's a good union employer collaboration, realized that dealing with linens on beds was injuring all kinds of people over and over again the same way. They actually invented new kinds of linens and implemented a sort of complete range of changes in how linens were handled, right from putting them on the bed, taking them off the bed, putting them in the cart, getting the carts down to the dump, where they more or less dump them for the laundry, out of the laundry and all the rest of it. And so everyone could see that things were getting better. And it wasn't just that a co-worker perhaps had to do more of the bed changes than the injured worker who's returning. Something that I took from, I think, pretty well all the presentations. In more complex long-term cases, report from WCBs, and I'll add in long-term disability insurers, including training programs for alternative work is really important. Some people just won't be able to come back to the same job. And Premji's presentation showed that workers, especially racialized new immigrant workers, workers with language barriers, often will have skills and abilities which just aren't recognized. They'll have talents and a lot that can be added to the workplace if only it would be taken advantage of. I was really impressed with the big data study around graduated return to work. Mentioning again, you can see probably it can't be a cookie cutter approach. It appears that graduated return to work may work better for sustainable employment than for some types of disabilities versus others. So in a general kind of way, sort of bridging that gap between the data and the workplace experience, it's really challenging. And I think the next sessions of this dialogue will make a big difference around that. And that's it. I'll stop sharing.
Thanks very much, Alec. So we'll go now to John Beckett. John, do you want to take over? You don't have a presentation, so just unmute yourself.
Yeah, no, my presentation is you get to look at my face while I talk. So, so lucky all of you. So you're not going to hear much different from me from what you've already heard. I'm calling from Geneva, where I sit as an employer representative for the Canadian employers at the ILO. And the ILO, for those of you who don't know, is part of the UN system that focuses on the world of work, from everything from health and safety, workers' compensation, decent work, and social justice. And I would say, without any exception, the majority of people here are experts with the social conscience, and you can't really spend time in this area without having that as your base. Anyway, I'm very honored to be speaking to you today from Geneva. I'm normally in Vancouver, but I'm here. So unlike Chris, who's trying to leave Newfoundland, tomorrow I'll be flying over top of Newfoundland. So I'm an East Coaster, so I guess it's about as close as I'm going to get home these days. So, so my day job, I'm the Vice President of Operations for the BC Maritime Employers Association, where essentially we run a $70 million organization that dispatches the workforce to move goods off and on vessels. I particularly run a $42 million training activity focusing on the movements of goods on and off vessels and on and off international vessels in the ports of Vancouver. I'm also responsible for strategic safety and rehab services for my 50+ members. Not to date myself, but 34 years ago, I got my career started in health and safety and learned very quickly that to be successful in health and safety, you can't only focus on the regulations and the law, but you need to focus on people. I've since gone back and received a fair bit of education on HR. I was honored to be an adjunct professor at UBC. So I met Anya teaching modern safety management in the School of Healthcare and Epidemiology. So, and I've always prided myself trying to find a way to move forward on difficult issues. And rehab and return to work are one of those difficult issues. As an employer, if you don't know what to do, where do you start? And where do you start is what the research tells you to do. So my background on rehab and return to work was implementing a system at a number of different organizations, one very large organization, 12,000 people, 9 unions, 18 departments, and a request from, it was a municipal environment, and it was a request by council to put a rehab system in place, because we'd done a good job dealing with the issues of prevention, but not a very good job in treating people who got hurt despite our best efforts. And frankly, my perspective as an employer, if you're not focusing on prevention is job one, but you also need to focus on rehab and return to work, because you're measured by your workforce, because it's the flip side of the same coin. You're measured on how well you prevent injuries, but also what do you do with those that do get hurt, and what do you do with that? Alan hit the nail on the head. If you want to, why do we do rehab? Well, the focus often is on saving money, but if you don't come at it with the right intent and the right focus, you're not going to save any money. You're going to frustrate everybody, and you're going to create yourself a pretty negative culture. I do continue to be an advocate for the BC workers' compensation system. I see that the Newfoundland Employers Association is on the line. I'm the president of the BC Workers' Compensation Forum as an advocate to the system, and the system really works only as a balanced system. And I've also had the luxury of being the chair of that particular board, the chair of the board of the Workers' Compensation Board. It's a bit of a mouthful. So I do understand how the system works from outside and from inside. Rehab and return to work systems are only successful if you are intentional in your actions to get employees whole and back to work. So how do your employees know that you're serious? Well, it's by what you say, what you do, and what resources you throw at the problem. You have to throw some money at it. You throw money at prevention, you need to throw money at rehab and return to work. After all, this is or could be a key employee engagement system that can drive productivity, can also reduce costs. And what other critical system in your business do you allow an outside body to manage or control it? So don't leave it up to the workers' compensation to manage your rehab and return to work or your insurance schemes, because for me, it doesn't matter where people get hurt, how you treat them and get them back to work is part of the process. Therefore, the rehab and return to work piece is a way to engage because it's your best interest to make sure your employees get back to work. So as employers, we're often asked or forced to act differently on workers' compensation and short and long-term insurance schemes, mainly because of the rules or because of the focus or because of people seem to think that they're different. They're not. People get hurt, people need to come back to work, people need help. So even though the schemes are funded differently and the rules are different, the outcome we're looking for is the same from both systems. So my advice is to develop a rehab and return to work system that works regardless of where people get hurt. Now, I'm going to talk about the workplace parties for a minute. So first, we'll talk about workers. And my experience tells me there are 3 types of employees that get hurt. There are those who are willing to participate and actively try to get back to work, and that's the vast majority. And it goes actually to some of the stats that Chris was talking about. There are those who are afraid and reluctant to participate, and there are those who don't want to participate for a variety of reasons. From my perspective, the approach to manage return to work and rehab in those 3 types is exactly the same. You focus on the majority. There are a variety of tools to deal with the other 2, but if you have it's not about we do talk about taking each case as to be an individual case, taking a team approach and tailored to the individual, but the process of engagement should be the same. And of course, as human beings, we often get frustrated with the third group, and we brush the other two with it, and to our own discourse. So it's the same for supervisors. So when employees get hurt, the role of the supervisor is critical in getting them back to work. However, when an employee gets hurt, the relationship with the supervisor changes, requiring a different approach. Again, my experience tells me when you can't figure out why someone doesn't want to get back to work, it's due to the relationship with the supervisor or the workplace or their peers. Dealing with, you need to deal with all of those in a proper rehab system through education and engagement. So who should do this? Well, the other piece is this is complicated. You've heard that from almost every presenter, that this is a complicated area and how you manage it. You need to have knowledge of medicine. You need to have knowledge of return to work. You need to have knowledge of workers' compensation and insurance schemes, organizational culture, the work at hand, people, et cetera, et cetera. So it's quite complicated. So it can't be done off the edge of someone's desk. You need to hire someone if you're an employer, and you're a large employer. This, of course, my experiences with large employers, this doesn't necessarily work on small and medium-sized enterprises, although components will. And those components, if you will, are having a rehab system that is, it's actually, my notes are exactly the same as Kim's, which is service coordination, health focus, work modification, a rehab plan versus a rehab program, which is comprehensive and coordinated, early intervention, stay at work if it's possible, education and supervision in peers. A consensus base is best, but if you don't have the LR climate to do it, you still need to do something. You can't just ignore the problem, because it'll continue to drive a negative culture. And above all else, advocate for your employees in the system if you think it's appropriate. So I'm going to close by saying that you're not alone. And there are great tools that exist in Canada. As I was doing my research here, there's some great documents that have come out of Ontario and the Institute for Work and Health, which actually simplifies the research into action points. So in conclusion, I'm happy to take any questions, and I wish you very well in your activities, because at the end of the day, it is rewarding when you get people back to work and you get them and you get them to help them get to be whole again. Thank you.
Thanks very much. Okay, so now it's your opportunity to pose some questions. I've been monitoring chat. I don't see any questions. Anya, did you see any?
Nothing yet.
Okay, so feel free to post some questions in chat, or if you want, we're going to try having people put up their hands if they want to ask a question. So Anya will monitor chats, and I'll try to monitor the hands if hands go up. Is there anyone who has a burning question or comment they want to make at this point in time? I don't see any hands, so unless I'm missing something, maybe what we could do is see if the panelists have any questions for each other while we're waiting for something to come in from the floor.
Yeah, hi, it's Chris here, and just really interesting and related presentations, but I also like the synthesis from both John and Alec. I guess the question or reflection I have is so, we've had a number of different types of research here. We're going to hear more research over the next couple of consultations. And so how do we best take this research in terms of, triangulating it into, policy and practice? It's good to have a conversation and reflect, but at the end of the day, what we're really trying to do here is to have evidence used in policy and practice. So I'm just wondering, I have my own ideas, but I need to hear myself talk. But I'm just wondering if other people, either on the panel or on the call, might have some thoughts there.
Actually, just before you answer that question, I'm just going to turn off the recording.